Good morning, everyone. Today I will be presenting my research topic on bone health in elderly men from rural southern India. As we know, osteoporosis in men is a under-recognized public health problem worldwide, with elderly people with an osteoporotic fracture being on increased risk of morbidity as well as mortality, and this risk being more in men when compared to women. Prevalence of 8 to 20% of osteoporosis in men has been reported from India. With that, around 2 crore of projected Indian men will be at risk of osteoporosis. We needed this study as there is paucity of literature about the impact of lifestyle factors on risk of osteoporosis in elderly rural men, poor access to health, inadequate screening tools, increased prevalence of smoking, alcohol intake, and lack of proper post-hip fracture management being risk of osteoporosis in rural men. Objectives of our study was to study the prevalence of osteoporosis as well as to identify the pertinent factors affecting bone health in rural elderly male subjects of South India. It was a cross-sectional study done over a period of 18 months, and the study protocol was approved by Institutional Ethics Review Board. Healthy ambulatory men of more than 65 years of age were included from Kaniyamwadi block of Vellore district from Tamil Nadu. Subjects on medication affecting bone health, subjects with chronic systemic illnesses and underlying malignancy were excluded from this study. Sample size of 233 was calculated on the basis of a previous study. Appropriate statistical tests were applied, including logistic regression analysis, to find out the risk factor for osteoporosis at neck of femur. Assessment was done using a questionnaire which included socio-demographic details, anthropometry, physical activity, and socioeconomic status. Physical activity was assessed using an internationally validated IPAC questionnaire, which assesses activity in 4 domains, including work, active transportation, domestic or gardening, and leisure time. Total physical activity is expressed as met minutes per week. BMD at neck of femur and lumbar spine was measured by hologic DEXA machine. Relevant bone mineral biochemistry including calcium, phosphorus, vitamin D, PTH was done, and a single sample of ATM testosterone was also analyzed. So to summarize, we recruited 256 subjects from 13 villages of Kaniyamwadi block who met inclusion and exclusion criteria by simple randomized sampling. They were given a questionnaire and biochemical investigations, and BMD DEXA was also done, and results were analyzed. Mean age of the subjects was 70 years, with around 2/3 of the subjects had a BMI less than 23 kg per meter square. 80% of the subjects belonged to lower, middle or upper lower socioeconomic class. 2/3 of the subjects were found to be physically active, 1/3 of them having a history of previous fracture, and 1/4 of the subject has a significant smoking history. 25% of the subjects were found to have osteoporosis at femoral neck, whereas osteoporosis at any site was found in 36% of the subjects. On comparison of baseline parameters, subjects with osteoporosis had were older, had significantly lower BMI, and were found to be less physical active. Further, serum calcium, serum albumin, and serum vitamin D levels were significantly lower in subjects with osteoporosis at femoral neck as compared to subjects without osteoporosis. There was a positive correlation between BMI and BMD at both lumbar spine as well as femur neck. Similarly, 25-hydroxy vitamin D also positively correlated with BMD, and PTH has a significant negative correlation with BMD. On logistic regression analysis, on univariate analysis, adequate vitamin D level, more physical activity, and younger age were found to be protective for osteoporosis. However, on multivariate analysis, only found to be protective for osteoporosis. So in our study, prevalence of osteoporosis was found to be higher as compared to the other studies from India. Vitamin D deficiency is an important modifiable risk factor for osteoporosis in men, with other risk factors being inadequate physical activity and advancing age. Limitations of our study was we use a simple random sampling, which might not give the better representation of the community. Lifestyle factors of the rural men are different from urban, so the scenario might not be the same in the urban setting, and we analyzed only a single sample of ATM serum testosterone for assessment of hypogonadism. To conclude, ours is the first community-based study to assess risk factor for osteoporosis in rural elderly men from India. Osteoporosis in rural South Indian men is a major public health problem, with vitamin D deficiency, advancing age, and inadequate physical activity being the important risk factors for osteoporosis in elderly men.
Will you treat these men with any anti-osteoporotic agent who have been diagnosed with osteoporosis from this study?
Diagnosed with osteoporosis, sir? Yes, sir.
You will treat with what?
With bisphosphonates, sir, if they are.
Why? If I ask why?
We are seeing that the
They
fracture.
are otherwise asymptomatic. Most of them did not have fractures. Age, they are aged 65 or 70 was your mean age.
But
So
sir,
it looks like most of our elderly population will receive bisphosphonate. How will you counter my statement?
Sir, a fracture hip has it has been seen in studies that fracture hip leads to increase in morbidity as well as mortality. After 1 year of fracture hip, there
So
is increase
why
in
I am
mortality.
asking this is, will you base your treatment only on this BMD-based osteoporosis?
No, sir. Other risk factor for fall and all factors has to be taken into account for treatment, sir.
So, what's the quality of life? So, you have seen some patients who had a fracture, no fracture. So, have you tried to find how the fracture has affected their quality of life?
We have taken only the ambulant patients, sir.
No, that's what.
Yes.
See, you have taken only healthy subjects.
Healthy subjects.
Apparently.
Yes, sir.
So, whether the history of fracture or no fracture, has it affected the quality of life of the patient, of the subjects in any way? Have you tried to find out that thing?
We have not tried.
Okay.
In the univariate analysis, BMI was significant.
No, sir. BMI
BMI
was not significant, sir.
So BMI on
no,
the
no.
univariate analysis
On univariate analysis, BMI was not significant. Different.
wasn't significant.
No. Only correlation was significant. There are
Other than this vitamin D is always, everybody says it's due to, see, but vitamin D, they are all rural people, no? You think vitamin D is the main contributing factor?
it may be other things.
Did you use the Indian BMD comparison T-score, or you used the Caucasian hologic?
We used
T-score?
hologic, sir. Hologic.
Do you think the thing will vary, or results will vary if you use the ICMR Indian T-score?
It may vary, but they are not yet standardized, sir.
Thank you.